Good morning, everyone. Thank you so much for joining us for the NEMSIS PAC August State Training webinar. Today is Thursday, August 2nd. This webinar is intended for state and territory EMS data managers and their representatives. Kevin White is a data manager here at the NEMSIS Technical Assistance Center. His area of specialty is business intelligence. He will be sharing information about the state-level administrations of Naloxone dashboard. And I will now turn the time over to Kevin White.
Thank you, Monet. I appreciate that introduction. So as Monet mentioned, this morning we're going to be reviewing a single dashboard, which is the audience for that dashboard is state data managers. The topic of that dashboard is going to be Naloxone administration. The hope is that it will be useful to you, the state data manager, in your ability to track the utilization of naloxone within your state. Before we get to the dashboard itself, however, I always like to remind people of some of the resources that we have available on our website that are oftentimes helpful when viewing any of our dashboards, whether it be state level, like we're viewing today, or public. So some of those resources, many of the resources are here in our technical resources area. The section that is most relevant to us when viewing dashboards really is our data dictionaries and our XSDs. Particularly for people like me who don't have a healthcare background, remembering every single element and definition in the NEMSIS standard can be quite a challenge. And so having this data dictionary available to me is really helpful. And we have that available in two versions, the web version and the hard copy version. The main difference between those two is if you know exactly what element you want to look at, the web version is really great for that. If, however, you don't know the element, but perhaps you know a keyword, then the hard copy PDF is really the one that you want to look at because the web version is not searchable while the hard copy PDF is. If you are from a state that is not on the cutting edge of whatever is the latest revision to the NEMSIS standard, and you want to be sure that you are looking at the version of the data dictionary that is appropriate for your state, then you want to click on to the archive page here and scroll down through to find the version that you know is relevant to your state. Once you do that, we have all that information available to you, both the web and the PDF version. I find, as I said, particularly myself, who's not well versed in the healthcare field, having those data dictionaries available to me when I'm viewing or building a dashboard has been very helpful over the past several years. The last thing I want to show you before we start looking into dashboards is our under view reports is our public and our state training sessions. Today we're doing a state training session, but that doesn't mean that the public training sessions aren't relevant to you. We oftentimes produce a dashboard for multiple audiences. In fact, we already have a public naloxone dashboard available. And so the reason that's relevant is if you are looking at a dashboard that is, in this case, a state dashboard, and we haven't done a training session on the state version, there may be a public training session on almost exactly the same dashboard that you may find helpful prior to or as part of your review of a state dashboard. So I like to point that out because we don't always do a training on every dashboard for every version of every dashboard that we have available. All right. With that said, let's go ahead and go into state dashboards. Let me expand this a little bit. And then we're going to go into our version 3 dashboards. And you'll notice that the dashboard we have available that we're reviewing today is at the top of the list. You also note there's a user guide available to you here, and that's also really valuable. The user guide, if I click on that, I can show that to you, is detailed document that goes through the background of the dashboard, including its inclusion criteria. So what records we chose to include in the analysis for the dashboard, and how we chose those records, as well as a detailed description of each and every visualization in the dashboard. Oftentimes this can be very helpful when viewing a dashboard, or if you're sending a screenshot or a PDF of the dashboard onto someone else, giving them a link to this document or referencing it in some way, it can be really helpful. All right, let's go ahead and jump right into the dashboard. And as hopefully all of you know, our state-level dashboards are secured, which means you have to have a username and password to get into them. If you don't have a username or password, you can actually get one. I'm going to bring up a different, sometimes I'm using Edge, and sometimes Microsoft Edge isn't, I admit, the best web browser to use for our dashboards. So I just switched to Chrome here for just a second so I can show this to you. If you're a state data manager, or you feel like you're an authorized party of some sort belonging to a state government, and you should have access to this to our state dashboards, you can request an account from us right here on our website by filling out a form. That gets sent to us, and then we here at the NEMSIS TAC go through the process of verifying that you should have access, creating an account for you, associating that account with the information that you are authorized to access, and then issuing you a password. If you already have an account or think you have an account and you've forgotten your password, there's a link right here at the top as well that walks you through a self-service password reset process. That is the same as you would see on most major websites these days, to allow you to easily reset the password yourself. You enter in your email address, you're issued with a temporary password, and then you can go ahead and reset that to whatever you like. All right, back to our dashboard, and I'll go ahead and click on that again. And here today, we're going to be demonstrating our dashboard with data from the state of Oklahoma. Oklahoma was kind enough to authorize us to display their state-level information to you today. I'm going to be using a test account. These are accounts that we here at the NEMSIS TAC use for testing purposes when we're building our dashboards. I emphasize that because, just so you know, that we don't have a record of your passwords. That's why we have that password reset process. But we do have test accounts for everyone that allows us to see exactly what you, the state data manager, would also see. So here in this prompt, you would enter your username and password. And as I'm going to do right now, and sign in. And then up will come the dashboard. And I'm actually going to switch to Chrome here because I already have this loaded up, just for the sake of time, so I don't have to worry about as many delays in loading of the dashboard. So here we are on the dashboard screen. We have this initial view. We also want to note we have a link to that companion document, which is the user guide. So that's available to you after you log into the dashboard as well. So this first view of the dashboard is actually not version 3 data, even though this is labeled as a version 3 state Naloxone dashboard. This is actually national level version 2 data. So using our version 2 data set, which is now closed, we use that to create a timeline at the national level just trend in naloxone administration with a projection for what would have been that for 2017, which was a transition year from version 2 to version 3 for many states. So this view is just there to give you a grounding in what was national trends. If we make sure I do that more carefully, sometimes I go a little quickly through these trainings. So what I did up here was I clicked on this little tab labeled Event Demographics and Details. I should note that you'll oftentimes hear me use tab and view interchangeably because one is just a more general term. View is a term that's utilized heavily by the tool that we here at NEMSIS Tech use to build these dashboards, which is a product called Tableau, which is a commercially available data analysis and visualization product. So if you ever hear me use tab or view, just realize that they're the exact same thing for the purposes of our dashboards. So I clicked on this view, Event Demographics and Details, and this is now using version 3 data, particularly version 3 data from Oklahoma. And I can verify that by going down to a little map that we have out here, and yep, the only information we're seeing is from the state of Oklahoma. If you're not from Oklahoma and you don't see your state, that's not expected, and we would sure like to know about it. Starting from the top and working our way down, many of you, maybe if you've been on previous trainings, this format looks a little bit similar. So please bear with me as I kind of go through these elements, these sections, for those of you who maybe may not be as familiar with how we structure our dashboards here at the NEMSIS Tech. So first section we have is data set size. So what this is, it's just an orientation section. It gives you an understanding of how many records, how many activations we're looking at, and how many EMS agencies contributed those activations. So it just gives you a sense of, that numerator, denominator as we're going through and looking at percentage and rates. It gives you an idea of where the information, how much information there is available to us. Down below data set size, we have our main filters here. And in this dashboard, we have two. We have EMS agency, which comes from D agency 02. If you don't know what that is the EMS agency number. The only reason I know that is because I've been asked it so many times. Otherwise, I'd immediately be digging into that data dictionary to find out what it is. And that's a list here of just EMS of those 143 agencies within the state of Oklahoma that can be used to filter the data. The next thing we have over here is our unit notified by dispatch date. And we have, this is our date picker, and we have, this date picker has 3 different methods by which you can window these 4,979 records. The first, most obvious method is this slider here, which we can just drag from either end to window the data. I went ahead and did that and just ramped us up to September 10th, 2016. I honestly don't know if that'll have an effect on the data or not. Oh yes, it had a little bit of an effect there. Okay. Nice. So let's go ahead and do that again in case people missed it. Notice that these numbers up here changed a little bit. And we'll just do that again so people can catch that. There we go. Oh, we lost one agency that time going from September to December. The next method that you can use to window the data using the date picker is to click on the date itself, and then you can use what is probably familiar to many people, a standard calendar picker here. And that's available, I want to mention that's available from both ends. The last method available to you is to, when you click in that date picker, is just simply type in a new date. For example, if we wanted to look from January 1, 2017, we could do that. Now notice this end date out here, which I haven't played with at all. It's set to August 31st, 2018. Now today's not August 31st, 2018. That's just a default that we have kind of set in there that can be ramped up or back. But I would note that it's a good discussion, it's a good time to discuss how frequently we update our information. Here at the NEMSIS TAC, all of our dashboards, whether they be state or public, are updated once a week on Sunday evenings. And the data that you submit to us through our web service, we process that data 5 days a week. We accept it 24/7, but we only process data. And for us, process means we go through the steps of validating it, and then tearing that data apart and putting it into our data warehouse that feeds all of our analysis. And we do that Monday through Friday, starting at roughly 2 p.m. every day. So if you submit a record to us at, say, 10 p.m. a Friday night, that record won't get processed until the following Monday afternoon. And it won't appear in any of our dashboards until the following Sunday evening. So I emphasize that to give you an idea of lag time on all of our reports and how available that data is to us, and therefore how available it is to you. So now that we've windowed our data a little bit, I want to go into the next section here, which is patient demographics. And here it is. We've got just these two little, just a simple visualization showing the percentages, male versus female only. We do have other selections available. We have an unknown, and then we have some not values available. But in this dashboard, we focus to just concentrate on male versus female. And this is the proportion. This is the relative proportion for which each of these genders were tagged in the activation as where naloxone was administered. Down below, we have some grouping of age in years. And notice that there's a spike here in 55 to 59. And say we wanted to look at, because that's our highest bin, so we wanted to focus just on that. All of our dashboards are highly interactive, which means that for us that we can filter that information, not only using those filters that I had here, but by using by clicking on any of the sections or elements in our visualization. So there I clicked and then unclicked just the 55 to 59. If, however, I wanted to look at, say, teenage cases where teenagers were involved, I can click that. I can click and drag using my mouse on those two bins. And while it's not exact, because we've got some ages in there that are not really teenagers, it's pretty close. We can kind of see, we can focus in on that. And to get out of that, all I did was just click in to an empty space, and that backed me out. There are a couple of other methods. Didn't mean to zoom Oklahoma out. A couple of other methods that we have available to you to back out of changes, filtering changes that you've made. Sometimes you get so deep into a dashboard and you've made so many selections, you don't really remember all the things that you did. So down here we have this little toolbar on the bottom left that allows you, gives you a couple different ways to back out of your changes. There's the undo, which is a stepwise undo, just like you have in, for example, a word processor that allows you to just iteratively take one step back on each click. And that's really helpful. But for me personally, I find the revert to be the most helpful. Revert means take me all the way back to the beginning, eliminate all of my changes, and give me a nice, clean, fresh dashboard as if I had done nothing. And that's exactly what we have now. Notice that the date, our unit notified by dispatch date is no longer windowed, and Oklahoma is returned to its natural prominence within our map. Are there any questions at this point before I move into the date and time section?
Hey, Kevin, it's Kathy Curley. How are you?
Hi. Good, good. Good to hear you, Kathy.
I do have a question. Can you scroll down a little bit?
Yes, absolutely.
I'd like to talk to you about, well, first off, is this total doses given? Because some patients could get up to 2-3 doses, or is this based off of patients? There's one patient, it doesn't matter how many doses they were given of naloxone.
So most of these visualizations are was naloxone administered, was it not? So it's just looking at administration rate, not number of dosages. However, we do have this right in here, this one visualization, which goes to the question of dosage. It looks and it's not precisely dosage in the sense that it's not the amount of naloxone in milliliters or in milligrams, but it's the number of administrations, and it's an average, and it gives you an idea. For example, for Oklahoma, the average number of administrations per activation is just a little over 1.
Okay, and the other question I have is at the bottom there, where it's complaints versus impressions. Okay, in 2.2, we used to have the overdose poisoning, and they kind of changed that up on us in the impressions. And now you have like opioid abuse, poisoning by unspecified. Okay, my question is, I see that in Oklahoma they use opioid abuse, and it's pretty high up there, because we don't know what they have taken. I'm talking of PA, of course, unless like there is definitely a needle sticking in the arm, or isn't that kind of like misleading because we don't know if it was opioid?
So I can't speak to that because I can only I don't have an EMS background. I don't have a healthcare background. I only have a data analysis and visualization background. So I can't speak to whether that's misleading or not. All I can tell you is that's the data.
Okay, and I don't have the background, the EMS or like you. But when I look at even in our own data, and I think at one point in time we did have top 15 impressions as being drugs, same as it was in complaints. And then when they switched it all up on us, we're getting conflicting numbers. Not that they're conflicting, but I'm wondering if that could be an issue. Clay, do you have anything on that maybe?
Yeah, happy to share. Yeah, actually, I just answered a couple of questions from other state data managers about this issue yesterday. It's a really, really important one. This visualization, of course, is only a presentation of naloxone given, right? So the provider in the field could see a patient who is actually experienced an opioid overdose or some other type of overdose, or even another type of complaint, and chooses to give naloxone regardless. We don't clearly have that information here, and in fact providers can't for sure answer that question either, right? So your point is very well taken. Here the impressions and complaints reported by dispatch are listed, but and so it's just going to be the best impression provided by the provider at the time. Whether it's misleading or not, I guess is true, right? I mean, if we all had the gold standard that comes from labs out of a hospital, we'd know whether or not their impression was correct or not. But it's just truly what exists on the medical record for that patient. So it's a great question. This truly is not a dashboard of people who have experienced opioid overdoses. This is a dashboard that provides information regarding every patient care record that indicated that naloxone was given?
Right.
It's a great question.
Isn't there a way that we could take the top 15 impressions, maybe put that overdose and poisoning? I know I used to do 2.2 data and pull it. I could one field in provider's primary impression, and it was usually overdose/poisoning. Now, if you look at it, there's change in mental status that it could be poisoning unspecified, and there's also opioid abuse. It's unknown what they've taken. You know, it just seems that it would be clearer if it would be easier, you know what I mean, if somebody says, you know, how many, they you know, I don't know, I just find the impressions now, like there's so many, and we're all kind of thinking, okay, could it be, what is it, what should it be? So,
yeah, Martin, would love to hear from you from Oklahoma. What?
Okay, the idea. Okay, number one, we have an opioid grant through injury prevention here, and they asked us to put those codes in there for opioid cracking. Okay, but you give naloxone or Narcan, you're thinking it's an opioid overdose. That was the thinking behind it. So even though it's an impression, you're thinking it is an opioid abuse because, you know, especially if the patient comes out of whatever state they're in. Okay, so, I mean, Narcan is usually given because you suspect an opioid overdose, so we therefore added it as an impression.
Okay.
Yeah, and this is Clay again. Maybe to kind of address your bigger question, Kathy. I mean, I think you're right. There were clearly instances in version 2 where we had too few options, where the bulk of the data came over to us. For example, cause of injury or incident location, where there was like 12 to 20 choices. The bulk of the data came to the national level and probably to the state level as other, because there were not enough choices. And now we're wrestling with the fact that there's like maybe too many choices, and you're pointing out a good example here for impressions, where if you want to come up with counts, you may have to combine several categories, right? Martin may have to struggle with that a little bit too, right? He's got here poisoning by unspecified, and he's also got opioid abuse, so he has to try to determine if those are to be added together, or if truly.
We have that same issue here in PA, so I know, you know, we're thinking, do we throw it in the schema, you know, so that because we're not here, we can't say it's opioid. And we don't diagnose. That's the way and to me, that's diagnosing that, yes, opioid abuse. We're just assuming, you know, and that I don't know, I have an issue with that. Not coming from the background that, you know, not coming from the EMT or the paramedic.
Yeah.
That's my concern. I'm a data person, I guess, per se, and when somebody says how many, I feel that we're losing a lot because I mean, I add it, you know, that's another field that I'll pick up, but, you know, but poisoning by unspecified, you know, and it can get really, really intense going through all those. So I just wanted to bring it and, you know, see if anybody else felt the way about it, and if there was anything maybe or something that we can do to, you know, eliminate all those. I don't know. Or not all of them. We need some of them, but just to bring it up in the mind, you know, in our heads and say, you know, is this an issue or is it just Kathy? Which is fine.
This is Monet. I just wanted to throw a thought out. I was reading an article last night provided by Tim Seplacki from New Jersey. He's talking about the responses to the opioid epidemic. And in their state, the paramedics are seeing patients up to more than once a day. And so maybe that is that could be considered the abuse when you know that you've seen this patient twice before in the previous day or in that same day. Just a thought.
Yeah, maybe the other thing I'll mention too, Kathy, that's kind of on the table to be discussed in part at the upcoming NEMSIS implementation call. There is this request for NEMSIS to add another element that's kind of acts as kind of a gateway element that would kind of potentially appear at the beginning of EMS calls that would call out events or activations that are particularly important to states. And so, for example, there could be like a gateway element that pops up that says, that has a list that says, is this a cardiac arrest? Is this a stroke? Is this a STEMI? Is this a suspected opioid overdose? And that could be valuable, right? Because then we could easily pick out the events, the patient care reports where a provider suspected, any of those type of things. So, yeah, I don't know what the best approach is here, but I think there's good people thinking about it. It's a tough one.
I mean, if you look at this one, the complaint, the people calling in with the complaint are saying, possible overdose or what, however they're calling 911. You look at, it's 17.9%. And then, I don't know, it just is a little unconscious fainting, which also could be, that's obviously a reaction when you overdose. So, it just is that great idea. So, hopefully they will talk about meeting in the next couple weeks. I'm glad to hear that it will be discussed, so thanks.
Yeah, thanks, Kathy.
Any other questions or discussion points before we move forward? Okay, so we'll breeze through this next date and time pretty quickly. This is what we have here. Just two visualizations, just looking at different scales of the administration rate, which we talked about earlier. One by month and year, and the other by time of day and hour block within the day. Just two simple tree maps to help you get an idea of where in time most of these administrations are occurring. The next thing that we have here in terms of date and time is this timeline that shows really two things. In its initial view, it shows the naloxone rate by day, and is one line, is the blue line, and the red line is a 2-week or 14-day moving average of that rate. And that moving average is for every day. So, for example, here on March 1st, the moving average is the average of the rate of the 14 days prior to March 1st. So that's the definition of a moving average. So when we go to March 2nd, then the moving average number is for the 14 days prior to March 2nd. So moving average is a statistical technique that is utilized to help smooth out volatility in a data set to give you a sense of the true background rate of what's going on and help you, the data manager, identify when an increase is a real increase. That is, it's trending up over time rather than maybe just a statistical anomaly or an outlier, a particularly high or particularly low day. Any questions on that timeline before I dig just a little bit more deeply into it? Okay, so I wanted to show you one other feature that we haven't talked about yet, and how to manipulate interactions with our visualizations. And that's particularly as it relates to any time that we have a timeline like this V3 rate. You can usually come down to the time axis, and you'll see a little plus and a little minus sign here. And if we click on the minus sign, what that does is it allows us to raise the what we call in business intelligence terms, raise the granularity of our view. So I just went from day up to actually week. And it gives us just a different view. Notice how both of our lines have become a little less jaggy. That moving average is still a 14-day moving average. It's just now we're looking at it at a different scale. So now I went up again, I went up to month. And then now I'm at quarter, and now I'm at year. So it can be helpful because sometimes it's not the most useful to look at this data on a per day basis. Maybe we want to look at a larger trend over time. And so we permit people to do that by allowing you to change the granularity on that timeline view. Now that doesn't change, unlike other ways of filtering or windowing, that doesn't change any of the other information you see on the screen. That is only related to the visualization, the timeline visualization. All right. Now we're into geography, which is a feature that is unique to our state level dashboards. As many of you know, we do not allow the public to see information at a state or within a state level. So this is something that is unique to you. And for you as the state data manager, as we here are logged in just as the state of Oklahoma, you'll only have access to the records that you submitted to us here at the NEMSIS TAC. So even if an incident occurred within your state, if you did not submit that information to us, maybe it was an incident that was responded to by an agency in another state, and they just crossed the border to respond to that incident. If you didn't submit that to us, you don't have access to it. So just be aware that is the case. Now, that being said, this is incident. Yes.
I've got a question about the map.
Yes.
This is Martin from Oklahoma. That overlay seems to be just a little bit off. If you look right below the word Oklahoma, right there, and that's McLean County, right there, you hover over that one. That's actually shoved over way too far. It should be
really
left. Yeah, that's not where McLean County is actually located.
Oh, that's really interesting.
Very interesting.
And you're also not showing Oklahoma County, which has higher. So for some reason, you're not showing Oklahoma County, which I'm thinking might have to be with some of the data still not in yet. So
yeah.
Well, what you're missing is Oklahoma County. That's why it looks that way.
That's why it looks that way. Okay. Okay. Well, that's good to know because we don't have. If the boundary itself were incorrect, that's something we would have to go to Tableau to get fixed, which we could do. So you think we're missing Oklahoma County information? All right, we'll definitely look into that and see if maybe we just don't have any Oklahoma County information, and maybe there's, to your point, maybe there's a problem in the incident county information that's being submitted, or maybe it's being submitted correctly and we're not decoding it correctly. We'll definitely check into that. Thank you for noticing that. We definitely would not have noticed that was a problem. One thing I will say, though, is since we're talking here at the county level, which is this initial view, we do offer the ability to also look at incident zip code view just by using that little toggle up there. And now we're looking at incident zip code. Very different. I would note that the distribution is somewhat different, and that is certainly one because zip codes have different boundaries than counties, and zip codes can cross counties. But also we should remember that zip code and county, while we logically think of them as related, they're often independently entered into into the field level systems. So sometimes there can be a disconnect there where a zip code can be marked in a record, and that zip code doesn't actually happen to exist anywhere within the county that's also marked in that record. But the main point there is I wanted to show you that you could look at this data, this incident data, in two different geographic groupings, county and zip. And then we have this heat map, colored over here by that naloxone rate, that administration rate. So, for example, this county over here, Sequoia County, has a high rate and above, has a rate greater than 1%.
So, Kevin, this is Clay. Just one quick comment there, maybe, and we'll follow up with you, Martin. But it's interesting if you switch that to zip codes, the entire state is at least has naloxone administration. I expected those zip codes to load only in the close to only in the counties that we're reporting. But yeah, maybe there is some issue with the data or how we're calculating counties. So we'll take a look at that from our end.
All right. So moving down into our last section, beyond the map, we have our clinical measures. We've talked a little bit about this already, which is average number of administrations, and we've talked a lot about complaints and impressions as well. I just want to note for people who didn't catch it, these are just the top 15 of each, so they're not the complete list. As we were discussing before, that complete list, the number of options there is really extensive. And so that complete list would be very long, and so we've chosen to focus on just the top 15 here. I'm going to go down to this the bottom right corner first before I go to the one up above it. So the bottom right is really focused on who administered, in a broad sense, the naloxone, and was it the EMS unit that responded to the call that administered the naloxone, or was it administered by someone else prior to that EMS unit's arrival? Now, it can be administered by both, and we don't have that displayed here. We don't have that double administration displayed here, but we do have this distribution of yes, no, and unknown. And the reason I came into this one first is because I really wanted to click on that yes, because that's been a topic of much discussion about what really are the components of that yes. So in cases where naloxone was administered prior to the unit arriving on scene, who administered the naloxone? And that's really, this visualization up above is showing that administration role. Who, in the cases where, in this case, 5% within Oklahoma, what's the breakdown of that 5%? And so we have a little tree map up here that allows you to walk through that, the complete selection of that 5%. And I think, where was it? Other non-healthcare professional accounts for 3.1% of that 5%. Layperson, around 1% of that 5%. And then we get into other healthcare professionals, student, that's interesting, down there at 0.3%. So I really wanted to make sure that I displayed that to everyone so that they know that they could look within that yes to see exactly what the effect is of putting naloxone out in the hands of non-professionals. And of course, if we don't restrict it in any way, then we get something that is really probably not surprising. That when we're looking at, and if we click on no, hopefully we should see a lot of healthcare professionals, a lot of EMS professionals in there being the majority of the administration roles there. And so paramedics really combining those two is just over 80%, right? Let me get it down in here into the others that are pretty much dominated entirely by healthcare professionals. In fact, I don't even think, we're way down there to get, just patient layperson being way down there in the teeny tiny little corner. Last thing before we close up, I realize we have 10 minutes, and I want to be respectful of people's time. Is I want to point out we have this little subscribe button down here, and many of you probably receive our weekly email on data submission summary. This is if you wanted to subscribe to this dashboard and have it delivered to you every Tuesday morning as well, you can just click that subscribe link down at the bottom, and then from there we can look at, we can select either this view or the entire workbook, and you can have that sent to you on a weekly basis. I wanted to make sure I covered that because that's an important point before I go into the very last view that's available to us on this dashboard. Here we are on the last view, the very last view, which is social and economic factors. And it really only has one main visualization, which is right here. What we've done here is we've taken information from the last national census and combined it with NEMSIS data at, I believe it's at the county level, that we've combined this information with different measures of socioeconomic status. So you can see that the distribution, the relative rates for the naloxone rate within there. By default, we have it here on percentage of adults that report excessive drinking. And when that's 6, you can see that the highest concentration there is among 6 to 8%. And then we have a bunch of different selections here, everything from income inequality to number of primary care providers within the population. So multiple measures of socioeconomic status we have available to you to look at how that rate changes within those groups. All right. That is the end. So yes, Clay, go ahead.
Yeah, Kevin. So this is a unique visualization here, and I wanted to make sure that I understood it correctly, and that our audience does as well. That the size of the bubble relates to the number of counties that have that rate of a certain thing. Correct? So here.
Yes.
Yeah.
Let's go out to our companion document. And so that we can get that. Each county against corresponding rate. Yes, you are correct. So it's number of counties.
Okay, fantastic. So this is kind of like three-dimensional, right? So the size of the bubble is how many counties fall into that grouping of the topic. So here it's number of primary care providers. And then you have the rates. It looks like by decile, so you can look at all the different rates, and then the color is the concentration of naloxone administrations with for the entire state. So okay,
great, thank you.
Yeah,
looks like we have about 5 minutes left. So I'd better open it up for any general questions. Does anyone have anything that they've seen or that they have questions about, or something that they expected to see that they didn't see? Okay, that sounds great. If I will say that if there is something that after reviewing this in detail that you feel would be of value to add to this dashboard, please let us know, either contacting me directly through email or contacting Clay, and we'll certainly evaluate it and get it included into the dashboard as quickly as we can. So this dashboard is available right now. It's live on our site so that you can log in and utilize it, and please do so. And just, again, any other feedback you have would be much appreciated. Other than that, Monet, I'm going to turn, I think I can turn presenter role back over to you. I'm not sure exactly how to do that, but maybe you have to take it over. But otherwise, I think I'm done. Thank you very much, everyone.
All right. Thank you so much, everyone, for taking time out of your day to participate with us on this training. I just would like to remind you that we have a few more days where the annual meeting registration portal will be open. We will close it on August 8th. So if you have not yet registered, please take time today, if possible, to get the registration complete. And we hopefully will see you at the meeting. And thank you so much again, and have a great rest of your day.